There we go. Cool.
Okay, brilliant. Okay. And share, okay, I don't need to share screen, but the others would know how to do it. Others
Yeah.
was, yeah. And so shall we, I'll just admit Sheila.
Susan Wong.
Yes, she's our co-chair. So where are we? Are we admitting them?
Yeah, they're already here. Hi, everyone.
Hi. And it's my side chap in the chat. Hi, Sue. Hi, Sheila. How are you?
I'm good. How are you, Mina?
I'm all right. Thank you. Yes. Looking forward to your talk. As usual, excellent talk you give.
No promises, no promises.
Yeah. Hi, Sue.
Hi, Mina. Hi,
How
Sheila.
are you? So, there we go again. So it's going to be a fantastic session. We have some really great speakers here.
Yes.
How many people are you expecting?
I don't know because usually I make a note of it.
Yeah.
There were several people who were confirmed. We have to wait and see how many turn up. So
Cool.
Yeah, we've got 10 minutes.
yeah. So I mean, knowing my people, they probably come 5 minutes late. Yeah. So I've got Anama. So she's going to be helping us.
Great.
So that's great. Dr.
Hi,
Shetty.
nice to meet you all.
Okay. So
Good to meet you.
is Dr. Shetty in? So are you letting people in? I'm not handling
Yes,
them.
I'm letting them in, yeah.
Okay. Okay.
Yeah, we've got Dr. Shetty here as well.
Yeah.
How was everyone's day so far?
Very nice, thank you.
Good.
The weather's been nice as well.
It's quite warm, isn't it?
Yes,
End of
this
September, so it's like
this evening is warm. Yeah.
Strange weather.
Yes.
It's been
Heat
pouring
waves
with
and
rain
hurricanes.
in England. So just over the bridge, it's pouring with rain.
You know, I'm getting two separate links. I think people will only use the link which is on the poster.
yes.
If you all manage to get in, that link should be fine.
It worked for me.
Yes, it worked fine for me.
Yeah.
It worked for me too, and I was really pleased.
Oh, hi, Helen. Lovely
Hi,
to see you,
everybody.
Helen. Yeah, it's a long time no see.
I know. Life goes too fast. We don't do the important things, do we? We don't get round to seeing each other. Oh,
I am expecting Jean White as well. You just say she'll come.
Will she be wearing her hat with the feather?
Maybe I should have asked her. But we want to see you, no, Sheriff. Right. I mean, I can't believe it. This is our first talk of the year. Things just have been very busy. But we are compensating it by having 4 talks instead of 1.
That's great. And hopefully we'll get a good chunk of numbers in as well.
Yeah, yes.
Mina, how long is everyone going to talk for?
Okay, so I better tell you, Sheila is the only one who's keeping to the time. The other, then it's a 10 to 15 minutes. So as 15 minutes is allowed. Maybe I did say between 10 and 15. That's Sorry. And so, yes.
I always follow the rules, Mina, as you know.
Yes, you do.
And is everyone going to talk and people will discuss afterwards, or how's that going to work?
What do you suggest? I thought I will have the discussion at the end.
Yeah,
Or
fine.
should we? Yeah,
Okay.
so that's that way everybody would have had chance to listen to people, and then
We come because we're frustrated playing against an Iceland who are ranked higher than us. So
Dr. Shetty, are you able to share your talk?
Yes, let me
Okay.
try that now.
Hello, Leila. Sheila, do you want to sort of have your talk ready on the?
I was just going to read it. I can
Okay,
send, I can send it
that's all right.
after.
Yeah, that's fine.
I can do the animations then, you see.
Yes, I think we like that.
Animations, I think that sounds a really great idea. Let me just. No. Goodness. There we are. Hello, everyone.
No.
Are you able to see anything at all?
No, not yet.
So I'm asking it to share the screen, but it's not doing that. No.
You want to rejoin, get out and join again in case.
No, I don't want to do that because I had a bit of a trouble joining in the first place.
Okay, right. No, you definitely. No.
So,
Do you need to make co-host to allow that, Mina?
Okay, right, I'll do that.
I think that may be the reason.
In fact, all the speakers should be.
I'll make all.
Speakers.
It's not giving me the option of making him.
Let me try and make them
Yeah.
Okay,
Okay,
but Susan, I will
you-
make you co-host. Dr. Shetty, I'll make you co-host.
Okay, thank you.
Dr.
Mina,
Mower needs to be made
and Sheila Hunt.
Sheila.
Sheila.
And Jo Mower.
And
How do you
Jo-
pronounce? Is it Moore? How do you pronounce?
Professor Yousef also.
Yeah, yes.
2 seconds, I'm just going to get Jo Mower to.
Yeah, mower like a lawnmower. And I
Mhm.
was going to do exactly the same practice and do the screen share because we're not so familiar with Zoom as we are with Teams. Well, I'm not anyway.
So just share the screen, click on share the screen at the bottom,
Yeah.
and then click on whatever it is you want to share and then say share.
Shall I go for it?
Yeah, try.
Amazing. Although Sheila, I think you've just been made host somehow.
That's it.
You can
Yeah,
see me? Hi.
We've got Joe's slides. Yeah.
Fantastic. There we are. Thank you.
I'm trying to share now. I can see Joe's screen there.
It's still there, is it?
Yeah.
No.
No, it's fine. Yep, that
Oh.
looks fine.
Okay, we can see your screen as well, Zaheer. Hello.
Here's fine.
Now I can see. So what do I share? Do I share entire screen? What do I
So you
share?
you share the PowerPoint. If you've got a PowerPoint, you've got if you click on that, can you see that? And then click on the word share at the bottom.
Share screen.
Ah,
So share screen first, then click on the PowerPoint, and then click share.
let's see PowerPoint.
And then click share. You should see a green box that says share.
No, that's not coming up. You see, that's not coming up.
Ah.
Share system audio. It doesn't allow me to. Oh, now
Shivan
it's
used to share the screen. Sheila, I think you've been made host. Do you mind making me host again?
I'll do anything you want me to.
I don't know that somehow the host authority is gone. Will you be
Okay.
able to make me host and I can get everyone to become.
How do I do that?
So if you go on participants,
Yes.
and then you should see my name, Anamadin.
Okay, yes, I'm doing it. Okay. I can see it now. Where is it gone? Add paint chat.
Okay.
No, I can't see. Yeah, Sheila, can you make her co-host? I'm not seeing that.
So click on stop sharing. Click on stop sharing for the moment. Okay. So try again. So go to share and then click on the PowerPoint that you want.
okay.
Hi, Masuda.
And
Can
then
you see it? Yeah.
no, and then click on share again. There's a green box that says share.
That green box is not appearing. That's the problem.
Okay.
No, that might be because Hamsaraj has not been made a co-host.
He was just now. Okay. Yeah, that's true now. Okay. Now there's co-host. So try again.
Okay. So share screen and then PowerPoint.
And click on the PowerPoint that you want to share.
Yeah.
And you should see a green box on the bottom again saying share.
I can't see that green box. That's the problem.
Okay.
At the bottom of the screen, can you see participants, chat, record, reactions, whiteboard at the bottom of the screen?
Yeah, now I can see.
Okay, so in the middle of that menu, there's a green box that shows share screen.
I think you need to keep your mouse moving as well to keep it live.
So that all those instructions disappear when I share and go back there. You see, when I share.
Or would you like to send it to me and I can do it for you at the time? Would you have animations?
No animations. But let me. Can you see my screen at all?
No.
No.
Oh. That's strange. One participant can share at a time. Multiple share simultaneously. Okay. So now try that again.
Okay, so
It appears temporarily and then it disappears. Can't understand that.
Okay, so while Dr. Shetty is trying to figure out with the sharing the screen, Sheila, do you mind going on the participants page?
Yes.
And then you should see my name. So Anna Martin.
Can't see it.
So Anna dash.
Oh, I'm not in. Yeah. Okay.
Yes. So if you press the button next to that, like I think there's more. And then so there's a drop down. If you make me host,
Okay.
then I can start giving Zaheer also co-host so they can share their screens. Amazing. Thank you.
Hamsaraj, I'm sending you my email if you want to send it to me.
Okay, okay.
It's in the chat.
Have we not made Zaheer co-host?
No, I'm just making him co-host now. Okay. Sheila, you're not co-host, so I'll make you co-host. Shiv, any other speakers? Is Shivani a speaker?
No, no.
Helen, is Helen speaking?
No, there are only 4 speakers.
Okay, cool. Amazing. Amazing. Dr. Shetty, how are you doing with the sharing?
Yeah, I've saved it as a PDF now.
Mm-hmm.
So
Do you want to send it to one of us?
I've sent my email. If it
Yeah.
comes, I'm happy to show that.
Yeah. Well, I was just thinking maybe if he's having problem, shall we start with the second speaker and then he can join us?
Susan, I'm not sure your email address has appeared in the chat yet.
I sent it directly to
Oh,
Hans.
okay, fine. That's okay. That's okay.
Hopefully it has arrived. You're fine though, Jo, aren't you, with doing it?
I hope so.
I'll send in case you also would like to do that. I'm happy.
Let's hope.
I just tested my presentation a couple of seconds ago. Did you see it flash up on the screen?
Yes.
Yes, yes, yeah. So, Dr. Shetty, are you there? I think he's not.
yeah,
I'm
there. Yeah.
okay. So, have you sent your talk to Sue Wong?
I can do that. What's your
I've put it in the chat for you, Hamsaraj.
Okay. I can't see it in the chat.
Okay, I'll send it.
Can you send it to me? You have my email address.
Yeah, I can do that.
And then I can pass it on to Sue.
Oh.
Okay, great. Jo, I've just received your message.
Okay, so shall we start? Dr. Shetty, are you okay if we start with the
Yeah.
and then we sort out? Yeah. So, okay. Um, I've got Masuda on screen. So,
I'll turn my camera off. Shall I?
yes, please, can you maybe, and then anyway, I'm sort of okay. Yeah. Okay, so great. Good evening, everyone. Welcome everyone to our next series of healthcare lectures. My co-host this evening is Professor Su Wong, who will take your questions right at the end. Please leave your questions in the chat box, and we are recording the talks. We have a fantastic lineup of speakers. Without further ado, our first speaker today is Jo Mower. Am I pronouncing your name right?
Yes,
Jo?
you are. Yes, you are.
Yeah, sorry. So or Dr. Jo Mower is an emergency medicine consultant in UHW with a portfolio of roles. He was born in Cardiff, went to university in London to study biochemistry and genetics, and returned to study medicine in Cardiff University, intending to pursue a career in clinical genetics. However, she became interested in acute care and embarked on a training program in emergency medicine, A&E in South Wales. She has held the positions of Vice President for the Royal College of Emergency Medicine, National Clinical Director for Urgent and Emergency Care, and currently she is the Digital Lead for Urgent and Emergency Care and an External Examiner for Cardiff University. Over to you, Jo. Thank you so much.
Oh, thank you. Thank you so much for inviting me here this evening. It's very kind. And hopefully I'll do justice to your title, The NHS at 75, where we have been and where we are going. And I am going to elaborate on my story. And you've kindly already introduced me as Jo, as a consultant in emergency medicine here in Cardiff. First things first, I apologise, my voice is a bit croaky, but I hope you can hear me clearly and you can see my slides. So yeah, I'm going to tell you my story, and you're quite right. I qualified in Cardiff back in 1995. So I guess in terms of the NHS, I'm approaching middle age. I was the last SHO in A&E, as it was in those days, and was lucky enough to move from the Cardiff Royal Infirmary to the current emergency department based in UHW. I completed my training in South Wales before becoming a consultant in Cardiff in 2004, when I became the lead ultrasound trainer for the Royal College of Emergency Medicine and hosted the first membership exam in Cardiff for the Royal College of Emergency Medicine back in 2008. I then became clinical director for emergency medicine in 2012, and I had 3 aims. The first aim was to develop academic emergency medicine in Cardiff, and I did this by working with the Deanery and Cardiff University to appoint the first professor in emergency medicine. Once we had the professor for emergency medicine, we could then appoint an academic trainee in emergency medicine. And we decided to build upon my knowledge I'd gained from supervising and mentoring students in Plymouth University during an intercalated BSc. And I'm glad to say that first academic trainee is now a consultant in emergency medicine in Merthyr and is in the 6th year of delivering the intercalated BSc for emergency medicine and pre-hospital care. My second aim was really to develop paediatric emergency medicine in Cardiff. At that time, anyone interested in pursuing a career in paediatric emergency medicine had to go to Bristol. But I managed to set in stone the first paediatric A&E consultant, and then subsequently we could deliver paediatric emergency medicine training by working with the deanery. And I'm glad to say that that's just grown and grown and grown. My third aim was to develop a major trauma centre. Some of you on this call may remember the South Wales Plan, and it was all about reconfiguration of emergency services in South Wales, although we couldn't call it reconfiguration at the time. But back in 2012, when we were discussing the South Wales Plan, we knew patients that had gone to the London Trauma Centre, the first major trauma centre, were having better outcomes than patients didn't. And the reason being was that we were centralising services and specialties around the patient. So we actually made a real impact in improving patient outcomes, improving mortality or reducing mortality, and improving morbidity rates for patients experiencing major trauma. So that's just a bit of my background of where I've been in the last since I qualified. Now, when I was appointed to the Vice President of Royal College of Emergency Medicine, I was actually introduced to the National Programme for Urgent and Emergency Care, one of 3 government programmes at the time. And I became the clinical director for urgent and emergency care. And I was asked by the minister then to describe what good looks like for an emergency department. And this is a very busy slide, but it's basically my story. And there on the left-hand side is a summary of the clinical engagement, the collaboration, the co-production, and the networking to develop a set of care standards that any of you or your family would want to recognise if they had the misfortune of being a patient in an emergency department. Basically, on the right-hand side then is those care standards that we developed, and really how we wanted to put them into practice. And if I take you down to the bottom of the slide, we were lucky to get £1 million investment, which is a huge amount of money, to deliver some of these care standards. And these products basically reflect the Healthier Wales, the policy that is still in being now. And we start off with actually understanding what a good experience for staff working in an emergency department is. And we worked with the Picker Institute to develop that staff survey, so we actually knew what staff wanted and what staff were experiencing whilst working in the emergency department, unlike the NHS survey that doesn't drill down to individual departments. I also worked with the NHS benchmarking team to actually understand what benchmarking was telling us about our emergency department in Wales. So how we can understand our staffing, our infrastructure, our IT, but more importantly, the unwarranted variation that we have across Wales. Then I worked with digital colleagues to develop pioneering KPIs, performance measures beyond the 4-hour, so you actually understand from an operational point of view what patients were experiencing, and in particular, how long it was taking for patients to be triaged once they arrived in an emergency department, and how long it was taking patients to be seen by a clinician. And using these measures, we can then start to understand the patient pathway and break it down into what's causing the bottlenecks, but more importantly, what solutions, such as additional staff, can we get into place. And then last but least was actually patient experience, and worked with the Happy or Not team to develop tools to understand patient experience beyond the 4 phases. We'll actually drill down into what the patients were thinking about, or what experiences they had with environments, registration, communication, and their perception of outcomes. So a lot of work going on with describing that good emergency department. So we were working on this, and we always said that we wanted to shine a light on alternatives to attending an emergency department, at the same time as reducing crowding by improving hospital discharge. And then came COVID. And actually, at the time, as a National Clinical Director, I was in a really good place to help inform the latest policy for urgent and emergency care, the 6 Goals policy, which you may or may not have heard. Very briefly, Goal 1 is about that coordination and planning for patients at high risk of needing urgent and emergency care, so patients with comorbidity. Goal 2 is actually how we help signpost patients to the right place. So actually implementing 111 and latter developments such as Press 2 for patients with mental health to try and reduce those inequalities there. Goal 3 then is accessing to safe alternatives to hospital admission. So this is same-day emergency care or urgent primary care. Goal 4 is that emergency department response or the 999 response. And then goal 5 and goal 6 are that admission, that important admission for patients, but hand in hand with preparing for discharge on the day of admission. So we don't do sort of linear processing, waiting for patients to get well before we start talking about how we discharge patients, but actually how we plan for that discharge for day one and actually what the patient needs to get them home safely to make that discharge successful. I couldn't possibly talk about any of this with not recognising the challenges that it takes to develop and implement this policy further into practice. And those challenges are broadly broken down into the workforce. What workforce do we have? Anything that was at risk or fragile before COVID, as you all know, has become more amplified. The financial constraints we find ourselves operating in, there is no more money. So we can't do more of the same. We have to think differently. How we deliver value in health and going back to that healthier Wales and the quadruple aims there of delivering what matters most to patients and where we can make the most impact. And actually understanding our data, because if I'm honest, the data across urgent emergency care is pretty poor at the moment, with our top 3 presenting complaints being not known, not coded, and not specified. And that's really what took me into my current role is as the digital lead for urgent and emergency care. So the digital priorities are improving the quality of data. And we have something called the Welsh Emergency Care Dataset, which underpins those data standards across the 6 goals of emergency care there. So we actually know so much more about the system than what we're currently working with. And actually how we can expand on the learning from those NHS benchmarking findings in emergency care and apply the same principles to same-day emergency care and intermediate step-up care and step-down care, that community care there. How can we improve patient flow within the emergency department is my priority too, and actually working with the Get It Right First Time team and actually applying those principles to emergency care. And we always recognise that, as I said before, that we know that good care in an emergency department depends on those alternatives to emergency care traditionally delivered by the emergency department and reducing crowding and that hospital discharge and step down intermediate care. And then priority 3 is reducing the clinical risk for patients in the emergency department. And my particular examples at the moment is actually how we can use artificial intelligence. We know at times of stress that Welsh Ambulance Service advise patients to make their own way to an emergency department. And at the moment, we have patients in the waiting room with heart attacks, with strokes that aren't being seen. But using artificial intelligence and ways of assessing patients, such as e-triage, we can actually reduce those risks by understanding who is sitting on our waiting room. So in summary, where are we going? I've given you a very high level report of where I've been and my journey through urgent and emergency care. And where are we going for the next 75 years? Well, wherever we go, and in no particular order, we have to improve our data. Our data gives us the knowledge to inform service improvement. We have to consider roles using artificial intelligence. I've been lucky on my career developing new roles such as academic emergency medicine, paediatric emergency medicine, and new roles within allied health professionals. But we've got to start thinking and embracing artificial intelligence. Actually understanding value in health and how we can make our money, our investments go a lot further for the majority of patients. The impact of climate crisis. We know that after hot weather and cold weather, that we have increased demand, we have increase in heart attacks and strokes, and we've got to actually stall and promote or prevent that climate crisis having an impact on our patients experiencing urgent and emergency care. We have to reduce those health inequalities that have been amplified and exaggerated as a result of COVID. And we have to continue to influence policy to put into practice what matters most to our patients in urgent and emergency care. So that's a very quick whistle-stop tour. I'm sure there'll be thoughts and hopefully questions at the end. And thank you for your attention. There we are.
Thank you very much, Jo, for your brilliant presentation. Dr. Shetty, are you ready?
Yes, yeah, I'm ready. If Sue can
That's great.
run the
Brilliant.
slides
Okay.
from there. Thank
So
you
our
very much.
next,
I'm sorry for
our
the
next,
difficulties.
yeah, sorry, that's all right. So our next speaker is Dr. Hamsaraj Shetty. He is an inspirational leader, highly respected clinician, and a visionary. When Dr. Shetty arrived in Cardiff as a consultant physician in 1995, there was no specialist stroke service in Wales. He started the Wales' first specialist stroke prevention clinic in 1995. It was Dr. Shetty's vision and hard work that significantly contributed to the transformation of stroke services in Wales. He led the development of an acute stroke unit at Cardiff University Hospital, Wales in 2009, and a specialist stroke rehabilitation centre at Landock in 2013. He also led an award-winning stroke service chosen as the National Demonstration Project and was awarded the Charter Mark by the Prime Minister in 2001. Among many activities, he has made a significant contribution to multiple clinical trials for stroke, and he is nationally and internationally renowned in his field. Thank you, Doctor.
Thank you, Meena, for that introduction and also inviting me for this talk. Yes, this is my disclaimer. I'm a clinician and my job is to represent my patients. And some of the things I'm going to say may sound very critical of some specialties or some professional groups. That is not the intention. I'm just putting forward the facts as how NHS operates at present so that we can learn some lessons. It's not all bad, I'll assure you that. So let's start with the first slide, please. Yes. So we were on holiday in Switzerland last month, in fact, and it was a group tour, and most of the people were older people. And one particular guy, he just got attached to myself and my wife, and he was with us all the time. And as it happened, on the very last day, he became disorientated and very unwell. He was vomiting and he was having diarrhea. And so the group leader, she asked me to see him because I was the only doctor in the group. So when I saw him, I realized that he needs to be admitted to hospital. So we called an ambulance. This is in Switzerland. Okay. So ambulance arrived literally within 5 minutes. So she requested me to go with the patient on the ambulance, which I did. And as we were going, the ambulance clinician kept asking me questions and he was typing on his phone. And I knew everything about this patient because he had told me everything about his past medical history, what medications he's on, who he lived with, and what was his mobility like, and everything. So I could give the entire history to this ambulance clinician. And we arrived in hospital and we went straight into the ward. And there was a nurse and a doctor waiting. This gentleman went onto a bed. And so I asked the doctor, do you want to take the history? I can tell you about what's going on. She said, we've got everything. So what had happened was that the ambulance clinician, as he was typing on his phone, it was going straight to the doctor and the nurse who was on the ward. So treatment started. As soon as the patient went on the bed, they started treatment. So that is how the private healthcare works. So you might say that, so next slide, and you can skip the next slide and let's go on to the next one. So you can see private healthcare is excellent. You can get state-of-the-art treatments and very accessible in a very rapid fashion. But the problem is it is very expensive. I discovered that Swiss healthcare is supposed to be one of the best healthcare systems, but it is entirely based on insurance. Every Swiss citizen has to have compulsory insurance. That's how it works. But the next slide, please. The problem is that even in the richest countries, it is not possible to access high quality healthcare in a uniform fashion. In America, nearly 500,000 people go bankrupt every year because of healthcare issues, particularly diagnosis of cancer. And so it is not always feasible to give a high quality care in a uniform fashion accessible to everybody in the population. So next slide, please. And this is what Dr. A.J. Cronin, who was a physician at the Tredegar Cottage Hospital. He was also an inspector for the coal mines, medical inspector, who observed the iniquities in health care and the also the problems associated with private healthcare, with the quackery and corruption and so on. He was really very upset with what he saw, and he chronicled that in his famous novel, The Citadel. And this book became the bestseller and was awarded the best novel of the year in 1937, and in fact was made into a film the very next year. And I gather this book had a tremendous influence on Aneurin Bevan, next slide please, who was obviously the MP for Ebwale, and obviously Tredegar Hospital was not very far from there. And after reading the novel and influenced by it, his vision of developing a health service was to provide healthcare that was free at the point of use, available to everyone who needed it, paid for out by the general taxation, and to be used responsibly. So I'm highlighting the last sentence. Just remember that, because I want to emphasize that point. So NHS officially started on the 5th July 1948. So that's why we are celebrating the 75th year now. Next slide, please. So I'm just going to briefly go through what is good, what is bad, and where do we go from here in this short talk. Next slide, please. So what is good? I mean, we all know that NHS provides excellent, high quality healthcare to most people who need it. And especially emergency care, I don't think it is better. NHS has got some of the most dedicated, hardworking staff with wide-ranging expertise.
Yeah.
Independent research.
Dr. Shetty, we are losing.
Are you not able to hear me?
No, there were some interruptions. Yeah, we can hear you now. Yes.
Yeah. So now moving on to the next slide. So I'm going to go through some cases to illustrate how NHS works very well.
I think it's internet. Dr. Shetty, we can't hear you.
Exercising, and suddenly developed weakness on the left side of the body. And this was around 8:38.
There's a problem now. We can't listen. We can't hear you. Ah. Can you hear me, Dr. Shetty? I think he's frozen.
Try turning the video off. If you can hear, try turning your video off.
Can you hear us? I don't think he can. He's just frozen. Oh, this is one of the limitations of this online meeting. What should I do, Sue? Shall we just
Potentially go out and come back, I think, and without the video maybe. Ah, okay, no video now.
Oh.
Still can't hear anything though.
Can we send him a message in chat?
Yep, we can do that. He's gone. He might come back again.
Can you hear me now?
Yes.
Yes.
It seems to have disconnected. So when we saw him at UHW, we found that he had a clot in his right middle cerebral artery, but he had not sustained any serious injury to his brain at that time. Next slide, please. So we thrombolized him, and then we did a CT angiogram and found that the clot hadn't cleared completely, and there was a blockage in the main artery on the right side of his brain. So we referred him to our interventional neuroradiologist, Dr. Sujit Nair, next slide please, who did an angiogram and found that there was a clot there, and he removed the clot. As you can see, the blood circulation was re-established on the right side of his brain. Next slide, please. And he was left with very, very minimal damage to his brain. And this kind of blockage would have left him with loss of half of his brain otherwise. Next slide, please. In fact, he recovered completely within 24 hours, and we discharged him within 24 hours. In the olden days, when we didn't have this treatment, this person would have been wheelchair bound for the rest of his life, completely disabled. And obviously with the treatment he has received free of cost, he has regained his independence and he can be a productive member of our community. Next slide, please.
Yeah.
So the cost of this treatment was approximately around 8,500, maybe a little bit more than that. But the benefits from his personal point of view, for his family and for the community, it's incalculable. Now, if you don't take the clot like that, it's another example. This patient came, there was contraindication for thrombolysis, and the clot retraction treatment was not available when this patient came. You can see what has happened. This patient lost half of her brain and ended up in a nursing home. So that's you can see the difference between the outcomes in two patients, and so NHS can make a huge difference to people who can arrive in good time and have access to this treatment. Next slide, please. I had two experiences recently. My son was diagnosed with Hodgkin's lymphoma, and so he was treated at University Hospital of Wales. I have no complaints about the whole process, how he was managed. In fact, the hematology department, the teenage cancer unit, were absolutely wonderful from day one. The only problem I had was that when the biopsy was taken, we couldn't get a report for 2 weeks because the only person who could report was on annual leave. So I thought that was quite unbelievable, that there was nobody else who could report, and there was obviously a 2-week delay in establishing the correct diagnosis, and the treatment was established. But nevertheless, fortunately, my son responded very well to treatment, and he is completely back to normal now, thanks to the NHS and to the dedicated staff at the teenage cancer unit and the hematology department at UHW. The second incident was when we went on for a wedding in Alnwick near Newcastle, and we were staying in a hotel there. And after the wedding, at night, my daughter's ring got stuck in her ring finger, and we thought it will probably settle down overnight when she keeps her hand elevated. but that didn't happen. When she woke up in the morning, the finger had become really swollen and blue and threatening to develop into a venous gangrene or something like that. So we were really worried. So we checked in the Newcastle Royal Infirmary about the emergency department waiting time, and they said 5 hours is minimum waiting time. So we thought we'll just check whether any jewelers are around in the town, but unfortunately it was a bank holiday and everything was closed. As we were driving back, resigned to the idea of waiting for 5 hours in the Royal Infirmary, we discovered there was a small hospital called Alnwick Infirmary, which is like a cottage hospital. We thought we'll take our chance, and we went there, and we were let in by the receptionist there. Within 5 minutes, the job was done. So again, it's a just an incident to show how wonderful these cottage hospitals are. And unfortunately, most of the cottage hospitals have disappeared around Wales. So move on, please. Next slide, please. So I've given you a few examples of good practice in NHS. What is bad, I'm sure we all are aware of the waiting list, the winter crisis, the staff shortages, delays in introducing new effective treatments, such as, it took 12 years for us to introduce thrombolysis for stroke. We still do not have, full-blown, full-fledged endovascular service for stroke patients, for example. There's a lack of continuity care, which has been one of the most important adverse outcomes of the European Time Directive. We used to admit patients and we used to follow them up from day one until they are discharged. But now it is not the case. We admit patients and you may never see them again. So this lack of continuity of care has affected patient care and also training of doctors. Bureaucracy, underfunding, and mismanagement obviously are also contributing to some of these problems. Next slide, please. So I'm just going to give you a couple of instances which I have witnessed. One was, I was visiting one of the local hospitals, and I was walking back to the car park, and I saw this old man walking, really inching his way to the hospital, dragging a bag which was fairly heavy. So I asked him, do you want any help? So he said, yes, please. And so I picked up his bag and I walked with him, and he was going to go his dialysis. So I took him to the unit. The door was closed. I knocked at the door. Nobody opened the door. So after knocking a few times, I just opened the door, and there were about 4 nurses sitting and busily writing on their folders. Not one of them looked up to let us in or look at this patient who was coming to that particular unit. So I looked around and nobody seemed to take any notice of him at all. So I found a chair for him and sat him down. And then I went to the lady who was sitting right next to the door, who didn't bother to answer the door when we were knocking at the door, and told her, look, this is your patient and I have to go now, and can you please take care of him? I thought that was incredible. So bureaucracy has become more important than a patient. So, I mean, this is just one example. I don't think this happens everywhere, but nevertheless, it happened. And I've witnessed this in my own eyes. Next slide, please. So the next one is a patient who is a neighbor of one of my friends. So this lady is 88, and she's a very independent lady, and she has atrial fibrillation, and for which she's taking an anticoagulant called dabigatran. It's like warfarin. It prevents blood clotting. So that particular morning, she started developing right-sided weakness, and her daughter noticed this and contacted my friend, and my friend said, it looks like she's having a stroke. So he rang me and said, my neighbor seems to be having a stroke. So what should I do? I said, call an ambulance and send her straight away, because I was actually on call. I'll look out for her and send her in because I'm concerned that she may be bleeding. So see, they called the ambulance. It took 1.5 hours for the ambulance to arrive. And so my friend called me around 12 o'clock, and I was waiting at the front door of emergency department, and there was no sign of this lady until 2 o'clock. And I just looked around everywhere and I couldn't find her. Then I asked the emergency nurses, have you heard of this particular patient? She said, yeah, she's in the ambulance. She's outside sitting in the ambulance. And she had been sitting there for nearly an hour. So I asked, why is she there? Because there are no beds here. So I said, there are 2 beds here, but they are emergency department's beds. I said, this is crazy. I've got this patient who is probably bleeding in her brain. We have to make an exception and bring that patient in. So I spoke with this senior manager in the department who kindly allowed me to bring this lady in. So we did a CT scan. As you can see, there's a blood clot, the hemorrhage in her brain, and she was bleeding. So one of the problems with people who are on anticoagulants is that they will continue to bleed as long as they are anticoagulated. So we have to reverse the anticoagulation to stop the bleeding. So fortunately, we have a reversal agent called idarucizumab. It costs £3,000. Okay, so I gave her an injection of this idarucizumab, and it reversed her anticoagulation. And this is her CT scan after 3 months. Her brain is completely healed. She's independently mobile, and she's actually self-carrying. And in fact, her daughter told me that she even goes shopping now. So in spite of all the problems she had a very expensive treatment and was effectively cured. Next slide, please. But some people are not so lucky. You may have read about this guy, Gavin Thomas, who is a world-class sportsman. He won silver medal in the Brazilian Jiu-Jitsu competition in Rome around October, I think, last year. And just a couple of weeks later, he was training in his club near Royal Glamorgan Hospital. And then he developed signs of a stroke on the left-hand side. His coach recognized that he's having a stroke, so he called for an ambulance. And they were told that there is a 7-hour wait for an ambulance. So what they did the next best thing they could do. They took him to the nearest hospital, which is Royal Glamorgan Hospital, which unfortunately does not have a stroke service. Obviously, these people were not aware of it. The registrar in emergency department was new to that hospital. So he didn't know what to do with this patient. So he asked somebody there, whom should I ring? So they told him, ring Dr. Shetty at UHW. So my switchboard put the call through to me. Although I was not on call, I don't know how it came through to me. So he called me, and I recognized that this patient probably had a dissection of the carotid artery, because that's what happens when people have contact sports. Sometimes they rupture the wall of the artery, which can lead to stroke. And that's exactly what he had. Unfortunately, it was too late for him to have any kind of immediate treatment. But I recognized that he had a very big stroke. As you can see, all of his right side of his brain is damaged and it's swollen. So I asked them to transfer him immediately to the UHW for neurosurgeons to do an operation. As you can see, they removed the bone on from his skull to allow the swelling of the brain to expand under the skin. If that operation is not done, young patients particularly, they die because the brain crushes the brainstem because of the swelling of the brain. And I spoke to him yesterday. He's still in hospital, in YCR hospital in the Rhondda. And he's recovering reasonably well. But he's a young man who has been in hospital for 11 months nearly now, 10 months. So can you imagine the cost involved in looking after this man, and what is his personal cost and the cost to his family and to the community in general? His productivity is all gone now, and his sporting career is finished. And this could have been potentially avoided had he come to the right place at the right time. Next slide, please. So I've given you some examples of good practice and bad practice. I mean, I think there is a tendency to always to ask the government to give more money and invest more in NHS, but are we being responsible? I think this is a question the population as a whole need to be asking as well. In spite of all the education and everything, still around 14% of the people are smoking, and worryingly, the biggest group of smokers are the young people between 25 to 34 years of age group. And 25% of the population are obese. And alcoholism also is an important contributing factor for poor health. And during the COVID time, the incidence of or the alcoholism has actually increased. And 16% of the people now appear to be drinking more than recommended limits of alcohol consumption. Next slide, please. So the other important finding during the COVID epidemic was that the importance of deprivation. This is an illustration of smoking prevalence in different kind of communities. These are the professionals, these are in between groups, and these are the manual laborers and the lower kind of rung of the society. So the more deprived the people are, higher are the incidence of let's say bad habits like smoking, alcoholism, and also higher are the prevalence of hypertension, COPD, kidney disease, diabetes. So all these things are higher in deprived communities. So this is something that has also been highlighted in the Marmot report, which I'm sure you're familiar with. Next slide, please. So what are the challenges ahead for NHS? I mean, obviously, aging population is only going to get bigger, and older people have multiple comorbidities, and the incidence of dementia is increasing all the time. And in my ward, I would say about 70% of the people are over 80 years of age. Nearly 15% are over 90. And these people have multiple comorbidities, and these people are also in the community who are living with multiple disabilities. So we need to cater for all these healthcare needs for these people. Next slide, please. So where do we go from here? I think the important step should be to reduce disease in the population as a whole, rather than try to address the problem after it has happened. So we need to address the deprivation side of things. We need to promote healthier lifestyle. In addition to stopping smoking, I think reduction in salt intake will have quite a significant impact on cardiovascular and cerebrovascular health and renovascular health as well. We need to make use of the advances in technologies, as Joe has mentioned. Artificial intelligence is probably going to play a very important role. Electronic records, I gave an example in Switzerland how electronic records played an important role in reducing the time of delivery of treatment. What we need are better trained staff rather than more managers. If you want to run an effective healthcare system, we need good doctors, good nurses, and good staff, not managers. And I think the whole concept of managing NHS is kind of based on business kind of model is completely wrong. That's what I feel. Next slide, please. So to conclude, NHS is a great institution. I'm one of the biggest fans of NHS. And but I feel that there is too much of bureaucracy, too much of paperwork. And I think time has come for evidence-based management. Someone asked a soldier who was fighting in the Falklands War, who are you fighting for? Is it for the Queen or the country? He said, no, I'm fighting for the one who is on my left and one is on my right. So we should be fighting for our patients. Thank you.
Wow, thank you so much, Dr. Shetty, for a brilliant presentation. So let's move on to our next speaker, Professor Zaheer Yousef, who has been a consultant cardiologist at the University Hospital of Wales for the last 20 years. He trained at Guy's Hospital in London and specializes in the care of patients with heart failure and cardiomyopathies. He is the past president of the Cardiff Medical Society, secretary of the Welsh Cardiovascular Society, and currently he sits on the board of the British Society for Heart Failure and is the heart failure ambassador for the Pan-African Society of Cardiology. He is also the honorary cardiologist for Cardiff City Football Club and is confident that the players' hearts are strong enough to get them at least to the top 6. Today he will be sharing his thoughts and experiences of how the NHS has coped in his specialty and looks forward to the future.
So thank you very much, Meena. Thank you for your very kind introduction, and thank you, Susan, for inviting me to talk today. So I'm a cardiologist, and I'm going to be sharing some of my experiences and just some thoughts about where the NHS is and where it could be going. So I'm going to start off with a little timeline. I'm going to start off with a timeline. So this is the history of cardiology. The first pacemaker that was implanted soon after the inception of the NHS. So the first pacemaker was implanted in 1958. And it's an interesting story, actually. So Earl Barkan was actually a TV engineer. He was interested in electronics, and he was making prototypes of pacemakers. He was also a keen musician, so he had a metronome, and he was playing on his piano, and he was using the TV technology that he had in those days with the metronome and the timing to work on prototypes of pacemakers. Senning was a thoracic surgeon, and Larson was actually the patient. And Larson was a man in his 30s who had sick-sinus syndrome and long periods of arrhythmia and bradycardia. And he was actually admitted to hospital for 6 months because he was having recurrent episodes of asystole, which required cardiac arrest treatment. So he was actually an inpatient for 6 months when Larson's wife actually heard about Senning and Barkan working on the world's first pacemaker. So Larson's wife went and met Barkan and Senning and said, "I want you to implant this in my husband." And they both turned around and said, "Look, this is a prototype." It was actually made out of an old-fashioned Kiwi polish box, which is why pacemakers are actually the shape they are at the moment. Anyway, Mrs. Larson was a very formidable woman, and a week later, her husband got the pacemaker, and this was in 1958. And a few years later, so Larson actually survived. He only died a few years ago. In fact, Larson, the patient, outlived both the surgeon and the engineer who made his pacemaker. And a few years after the pacemaker was implanted, was the first time that the Nobel Prize was awarded to 3 people: an engineer, a surgeon, and the patient as well. All 3 of them got the Nobel Prize in medicine. I think it was in the 1960s. But a couple of years after that, the NHS actually adapted and saw this technology. And the first pacemaker was implanted by Aubrey Leatham in London in the 1960s. So just 2 years after the world's first pacemaker, we were actually delivering that treatment on the NHS here in the UK. And we all know Christian Barnard in South Africa performed the first heart transplant in 1967. Well, a year later, Donald Ross, who was a surgeon at my old medical school, Guy's Hospital, he performed the first UK heart transplant just a year later. So again, the NHS adapted and delivered this, really groundbreaking treatment. And then in the 1980s, we had the first angioplasty in the UK. And in 1988, we had the first coronary stent implanted in the UK. So these are all big landmark cardiac interventions that have taken place, and the NHS has adapted and delivered these for our patients almost immediately. So now we move to the 1980s, and I put this timeline up because this is when I started medical school. So I actually started medical school in 1985. And a lot of people ask me why I'm interested in heart failure. And what is it that attracted me to heart failure? And the answer is that I remember sitting in a lecture theatre in 1985 when one of the biochemistry lecturers came in and talked about this condition called heart failure. And in those days, the only treatment for heart failure was diuretics and digoxin. And if you were diagnosed with heart failure and you got those treatments, your 6-month survival was about 50%. So 50% of people died within 6 months or after 6 months of a diagnosis of heart failure, which is atrocious. That's, worse than most cancers that we think about today. And in the same lecture, the biochemistry tutor who was lecturing us talked about these new medications called ACE inhibitors. And he gave us all the biochemical pathways and things about, and all the theory about it. And he said, mark my words, these ACE inhibitors are going to come in and they're going to revolutionize the treatment of heart failure. So fast forward 5 or 6 years, I was now qualified and I was seeing patients with heart failure and I was actually treating them with ACE inhibitors. As a junior doctor, all the landmark trials for aldosterone antagonists, digoxin, beta blockers came in. And this is through my lifetime of managing patients with heart failure. I've actually been able to see these massive improvements in the treatment of heart failure patients. And then when I was coming to the end of my training, we had the defibrillators and the biventricular pacemakers. So I went off and I did a fellowship in that, learned how to put these devices in. And then I was appointed in Cardiff in 2005. And one of my roles was to actually develop heart failure services and introduce these new device treatments for heart failure, both in Cardiff, but also for the rest of Wales, and train people how to implant them. So now in Wales, we have a system where virtually every heart failure patient who's diagnosed with heart failure will get all these treatments, including these devices. And now we can actually expect our patients to live more than 5 years with their diagnosis of heart failure. So whereas in the 1980s, their 6-month survival was 50%, now we're looking at 5-year survivals of 50%. So that's been a dramatic improvement in the heart failure trajectory of our patients in my lifetime, which spans across most of the NHS. And the NHS has adapted and delivered these treatments. But heart failure is a really, really common condition. We're actually going through a cardiovascular epidemic. The prevalence of heart failure is increasing. At the moment, it's about 2 to 3% of the general population. So we have about 40 people joining this call today on Zoom. Statistically, 1 person will have heart failure. That's how common it is. And it's going to get even more common, and it's going to become an even bigger burden on the NHS because, as Hamsaraj has just said, our population is aging. We're getting elderly patients with multiple comorbidities. And so heart failure is going to be a really big challenge for the NHS. And at the moment, when you look at the NHS expenditure, 2% of the whole NHS budget actually goes on managing patients with heart failure. And undoubtedly, some of these costs are due to treatments. So drugs are expensive. Now, fortunately, a lot of the drugs, the ACE inhibitors, digoxins, beta blockers, are now generic, so they don't cost much. But every 3 to 5 years, we have a new treatment for heart failure. The most recent ones are the SGLT2 inhibitors. And of course, they're not generic. And so there is a cost involved in that. The interventions, so I've mentioned the pacemakers and the defibrillators, they still cost £10,000 to £15,000 each. Many of these patients will have had bypass surgery, will have had mechanical valves implanted. Some of them may have had heart transplants. They may have LVADs, left ventricular assist devices, which cost about £150,000 to £200,000 each. So treatment costs are going to certainly make up a large proportion of this expenditure. But the biggest cost is hospitalizations, because these patients with heart failure, it's a revolving door. They keep coming into hospital, and every time they come into hospital, they spend on average 10 to 14 days in hospital. And that's if they don't develop any complications. And on average, you have 2 hospitalizations each year. That's where a lot of the costs are. And as patients get older, as they get more frail, as they get more multiple comorbidities, their healthcare requirements are going to increase both in hospital, but also when we do discharge these patients at home, they're going to need a considerable amount of support in the community, both in the social care services, primary care services. And so I completely agree with Hamsaraj's comments in his last talk, where there has to be greater integration of social care and healthcare, because this is going to be a big challenge for us in years to come. So in Cardiff, as I said, I was actually appointed here to develop secondary care and tertiary care heart failure services. Some of you who've come to my talks before will know that, we have, quite a mature heart failure service now. We look after patients with inherited cardiac conditions, the devices I've spoken about. We look after patients with neuromuscular diseases. We do quite a lot of work on sports cardiology, chemotherapy cardiomyopathies. So there's a lot of tertiary high-end heart failure work that's going on, but we also have to look after our secondary care population. So we do deliver a lot of community clinics, day hospital work, optimization of patients, early diagnosis of patients in the community, and then getting them on the right treatments. And this is all packaged in a population of patients which are high risk. It's a highly prevalent condition. As I mentioned, these are elderly comorbid patients who have recurrent hospitalizations. So this is what we were dealing with. This is what the NHS was just about coping with 3 or 4 years ago. And then COVID hit. And this was an opportunity for us now to try and look after these patients and do the best for these patients, because these are a very highly vulnerable group of patients. If you remember when COVID came, there were all the risk groups of patients. Heart failure was one of the high risk patient groups, and they're the ones who were offered the vaccines very, very early. So as a group, I called the team together and I said, look, this is major. We are going to have to change the way we work. And so we completely restructured our timetables. We completely restructured the way we worked, and we had daily multidisciplinary team meetings. We went through all the patients we were worried about. We had a very, very active WhatsApp group, and we were WhatsApping each other all the time about patients, WhatsApping ECGs across, echo pictures across and things. We set up a shared folder on the health board's server so that we can share protocols and processes. And as a team, I thought it was really, really important that we stuck together and we supported each other and we talked to each other and we worked together, because we were all in this horrible mess together and we had to do the best. It was all new for us. We were all learning on the job. We were all trying to do our best, but we needed to support each other. So the NHS was just about creaking. We had this very, very complex service that we were delivering, but then COVID hit. It tried to wobble it, but we tried to cope, and we made lots and lots of changes to that. So, we decided that we were, going to have to see patients and diagnose new patients with heart failure, because obviously there were always going to be patients who are developing heart failure. The incidence of heart failure is about 1 to 2% per year. But then COVID itself, I've spoken at this meeting before about the COVID complications causing myocarditis and heart failure. So we needed to see patients, despite all the social isolations and everything that was going on. We had to do this both remotely as much as possible, and for the highest risk cases, then we were actually seeing them face to face as well. But we had to use multiple platforms and use every opportunity we had. So Joe talked about electronic digital health. We tapped into every resource we could think of, posting ECG stickers out to patients, posting blood pressure monitors and heart failure monitors, heart rhythm monitors out to patients. We were trying to get their bloods done remotely. We were keeping a handle of all their progress on their journey. And we were able to really expand our digital platform and tap into external reports. So if someone was from the Rhondda Valleys and they'd had an echo 6 months earlier, we were actually able to tap into the Rhondda electronic databases and get the reports and the echo reports and look at the actual echo moving pictures and things. So these are all the things that we actually managed to do. And then we had, as I mentioned, we had these MDTs every day, and we were managing patients remotely, virtual consultations, Zoom consultations, WhatsApp consultations, and we were trying to keep very rigid documentation for all of this. And we made huge changes to our practice, the way we worked. And COVID gave us an opportunity to innovate, and we were free of all the normal shackles that you normally have to innovate. Usual barriers were totally relaxed. So, when 2 years prior to this, I remember going to our management structure, talking to them about accessing echo pictures from, the Royal Glamorgan Hospital. That was never going to happen. There were so many hurdles to go through. Doing virtual consultations on WhatsApp, so many barriers and hurdles to get through. But now we were actually able to innovate, and all the barriers were relaxed, and we just got on and did it. And we managed to, implement all of these changes in this NHS framework. So, we did lots of things, so optimization clinics, for example, these are really, really important. It's really important to get our heart failure patients on the right treatments. We expanded home monitoring of the patients. Exercise rehabilitation is really important. So we were actually doing Zoom exercise rehabilitation and exercise classes for our patients. We were titrating our medications by wearables that we were posting out to patients and then collecting the data electronically. And patients liked it as well. The satisfaction surveys showed that 90% plus were very, very happy with the way we were managing things. A lot of our patients have implantable devices as well. So these devices are actually connected to the hearts, and we are collecting, lots and lots of data. But before COVID, all that data was just being lost. But during COVID, we, sort of implemented a system where all that data from the devices is being up to a cloud and then down to our servers in the hospital. And so all the barriers and all the loopholes that existed before were taken away. And so now, once I've implanted a pacemaker in a patient, I send them home and I don't ever actually have to see them again, because electronically in real time, we are measuring the battery life, the device function, the lead parameters, the connections to the heart. We can tell everything what's going on with the patient. The patient doesn't actually doesn't have to come back into hospital and have any face-to-face checks. We can collect a huge amount of data, and that was only possible because we were allowed to innovate and make these changes and implement these changes. But of course, there's always going to be very high-risk patients. I mentioned the neuromuscular patients that we look after. Some of these patients do need to be seen face-to-face, and throughout the whole COVID pandemic, about 10% of patients, we were still seeing them face-to-face because we needed to, we had to. They were really decompensating. The one thing I knew was that if one of these patients came into hospital and we had COVID all around the hospital, they would develop COVID. And they would probably not survive. So it was absolutely vital that we kept seeing these patients, and we did everything possible to keep them out of hospital. So during COVID, we learned a lot. And I put this up just really basically to show how the NHS adapted during the COVID process. You know, one of the things that we all realized was that we have an absolutely fantastic NHS. The staff are second to none, able to adapt, you know, embraced change, you know, welcome change, were keen to do as much as they could for their patients. We were able to really rapidly implement digital technologies, something that we've been talking about for years and years and years, you know, going paperless. You know, we were able to do that during COVID. We were able to implement all of these digital technologies. The environmental benefits are huge, you know, less paper, less carbon footprint, patients not having to come to hospital all the time, you know, the car parking problems, the petrol costs, you know, there are lots and lots of other knock-on benefits to this sort of way of working. And what we were able to demonstrate throughout the whole COVID period was that there was no increase in heart failure admissions. So all this remote working of patients does work, and it does keep patients out of hospital. What did happen though was the very sickest patients, the ones with the really bad heart failure, the ones who absolutely had to come into hospital, they did come into hospital. We did end up admitting them. 50% of those patients then actually contracted COVID infection whilst they were hospitalized. And our inpatient heart failure mortality went up to something like 60%. And average inpatient mortality at the moment is about 10%. So we had a huge increase in our inpatient heart failure deaths. But I would argue that that was probably necessary, and it's probably not these patients really needed to be in hospital. And then they got super added COVID infection on top of that. There are obviously ongoing challenges. You know, IT hardware, software continues to be a real problem. IT support, you know, we have the tools, but they just don't work together. We've got multi-provider interfaces. You know, the Philips system doesn't talk to the GE system, which doesn't talk to the Welsh Clinical Portal. And then each of these interfaces and softwares has their own passwords. And, you know, I mean, I calculated the other day that just for me to get onto the computer and try and see one of my heart failure patients, I have to go through 16 different passwords for different programs, and it's crazy because some of these passwords, you have to change them every 3 months. And it's really, really difficult to keep on top of all that. Obviously, there are going to be governance and security issues. And one of the things that some of my patients have actually said is, although this is all very good, we mustn't lose sight of the fact that there are human beings at the end of you know, all these telephone calls and these emails and stuff. So sometimes patients do like to be seen face to face. We can't go completely remote, or we can't just rely completely on artificial intelligence and manage our patients remotely. So looking forward, and these are my thoughts, I absolutely agree. I totally am, you know, in awe of the NHS. I think it is an absolutely amazing service. It is the best in the world. As Nye Bevan said, you know, he started up and he wanted a service where every patient, every person in the UK, irrespective of race, color, creed, income, has access to high quality healthcare, which is free at the point of delivery. And I think that is a massive, you know, caveat that we've got in the NHS. We really do have to continue with that ethos. It's free of all commercial influences. Hamsaraj talked about, you know, you can go to Switzerland and get absolutely fantastic healthcare, but it does come at a cost, and there are always going to be commercial influences there. We really do have a highly dedicated and highly trained staff workforce. You know, people from all around the world have come to the UK to get trained in healthcare and how to manage their patients. That's something we really need to be proud of. And as we've shown in COVID, you know, certainly in my specialty, but every other specialty as well, we have a highly adaptable system which will change and try and deliver for our patients. But there are problems, and there are dark clouds on the horizon. We have a very fatigued and extremely undervalued staff at the moment, and this is something that really does bother me. There are critical workforce shortages. In cardiology, for the first time in Cardiff, we've actually got in our cardiac physiology department 7 open vacancies, which we just cannot point to. People are working 1 in 3 on-call rotas, and this is delivering 24/7 angioplasty. This cannot continue. People are leaving the service. We train people extremely well. We invest a lot of our time and energies in training these people, and then they leave. They either retire early, or they leave to go elsewhere. I look after a lot of junior doctors in our department, the F1 SHO grades, and for the first time this year, I've had 5 people in that tier, the junior doctor group, who have just come to me in tears and saying they're leaving medicine for good. They're going to go and do something else. They're either going to go into journalism, or they're going to go into pharmaceutical companies, or they're going to go into business studies or something. But 5 people this year. It's the first time I've ever seen that. It's very, very sad. And we've got an aging population. So, these things are only going to get worse because the healthcare needs are going to get worse as well. And the workforce is aging as well. So this is something that we really have to be very, very careful about. But there are, things that we can do to try and alleviate some of the pain. We're relying more, or we're sharing our workloads with allied healthcare professionals. So, heart failure nurses are now nurse prescribers. They are, clinicians. They're heart failure specialists. This is to be promoted. This is to be welcomed. So we are seeing other healthcare professionals taking on other responsibilities. We've talked about digital technologies, artificial intelligence. There are always new treatments coming in, genomic medicine, to really tailor our treatments, immune therapies. We've got minimally invasive interventions as well. But I think we also need a lot of enthusiasm from society and the politicians to help maintain the NHS the best in the world, which it currently is. But we need the drive from society and politicians to help us stay there. And I'll leave you with Nye Bevan's quote, which I think is absolutely brilliant. The NHS will last as long as there are folk left with the faith to fight for it. Thank you very much.
Thank you, Zaheer, for your thought-provoking talk. I'm sure there'll be lots of questions. So, and now, our last speaker is Dr. Sheila, trained as a nurse in Cardiff in 1969, and later as a midwife. She eventually went to university part-time at the age of 35, worked in the NHS and in universities in Wales, England, and Scotland, eventually returning to Wales in 2007. Sheila was awarded a PhD at the age of 50 and became a professor in 1996. She held a joint appointment with the Birmingham Women's Hospital and the University of Central England as the first professor of midwifery. She retired from Cardiff University in 2015. She was the Dean of the School of Health Sciences and Deputy Pro-Vice Chancellor for Staff and Diversity. Sheila is a lay member of WHSSC, All Wales Individual Patient Funding Review Panel, and a lay member of the Power of Discharge Patients Managers. Thank you so much, Sheila.
Mina, that's amazing. Thank you. I listened to that and I think it's time I went to lie down, isn't it, in a darkened room. First of all, can I thank the 3 previous speakers I learned so much, and I'm so impressed with the progress and the commitment. And Mina said to me, speak for 10 minutes, and I always obey the rules, you see. So I'm going to be brief with an overview. And as a teacher, I used to say, read the question carefully and answer only what is asked. So the question was, where have we been and where are we going? So that's my brief for tonight. And I'm writing this as a nurse and as a midwife and as a sociologist whose PhD was focused on poverty and health inequalities. And I find it very difficult to put down the things that I learned during that process. So to begin with, where have we been? So I'm going to tell you a story because that's how I work. So I want you to think about Mrs. Brown. And Mrs. Brown had a cholecystectomy in 1969. She was admitted with severe abdominal pain. She was slightly jaundiced. She was pyrexial. And the diagnosis was an X-ray. There was no CT scan. There was no MRIs. I think she had a blood test called urea and electrolytes. And I remember a lot of blood being cross-matched. She went to theatre and had a very long incision, and it was in inches in those days. It was at least 15 inches. She had a wound drain, a gallbladder drain, a nasogastric tube, an IV drip, and a urinary catheter. And as a very junior student nurse on night duty, I did hourly drip and suck. The pain relief was intramuscular pethidine. I did mouth care. I changed the position and I did the obs hourly. She had to stay in bed because that was the very best chance of getting a deep vein thrombosis and a huge incision. Some 10 days later, she was transferred to the convalescent home in St. Mellons, which is now a new housing development. My job there was to make the porridge and to serve the porridge with the other student nurses and do things called a tidy round. We did a gentle walk around the grounds, and eventually Mrs. Brown went home. She probably survived after a 6-week stay in the NHS. There were no lifting aids. Lots of nurses had bad backs, and lots were very kind and compassionate. It's very, very difficult now to imagine a world without Google. I had one surgical nursing textbook, a student nurse dressed in yellow, and my salary, just for fun, was £365 per annum. There were no journals, and a literature search was done by hand, walking around a library, finding the journal and photocopying it. So I could offer many more stories: community midwifery in traveller caravans with very high perinatal death and stillbirths. Things have moved on. So where are we going? Diagnosis of gallstones is quick, accurate. Cholecystectomy is done via laparoscopes. Recovery is relatively quick. As we've heard this evening, many more procedures are quicker and safer. My father's open heart surgery for coronary artery disease has been replaced by stents and the like. And the IT revolution is changing healthcare beyond recognition, especially apparently once we move away from the fax machine. There are still lots of kind and compassionate nurses, but recruitment's falling off. Nursing is in clearing this September with vacancies, virtually unknown. The media storm is influencing recruitment. So nurses today are now educated to degree level. They're not simply trained, but taught how to think, how to research, how to evaluate evidence, using the skills of critical appraisal. And they're taught to be kind and caring. They're taught about ethics, research, evidence that's tested. They're taught about communication, compassion, leadership, teamwork, a little bit more than the drip and suck, doing the obs and making porridge. And advanced nurse practitioners are now highly trained and educated specialists who are making, as we've heard tonight, an outstanding contribution to healthcare. But I want to talk for a minute about the media and politics in health and social care. The media focuses on waiting lists, on targets for operations, on the kind of conditions where the private sector thrives. There's no media coverage of the absence of mental health beds on a Friday night. Very little attention is given to long-term care for the elderly, for dementia, diabetes, depression, long-term conditions, long COVID, it's generally ignored. And people with disabilities are frequently cast as scroungers or benefit cheats. Mental health provision receives scant attention until someone's killed or injured by a patient with schizophrenia. It feels to me that social care belongs to nobody. Politicians ignore it, ask Theresa May. Yet caring for a growing elderly population, as we've heard this evening, is an urgent, under-prioritised healthcare need in the UK. The media simply refers to bed blockers, not as human beings caught up in a system where exit routes are blocked and where social care often doesn't happen. Funding for social care is politically too sensitive to be discussed, and the dementia tax contributed towards Theresa May's election defeat. I thought it might be worth sharing with you some of the anxieties with the middle classes in 2023. So what do my largely middle class friends, contemporaries see now, and what do they worry about? Well, they all feel sure that the NHS will probably continue to provide first-class emergency care, if you can get an ambulance. Most feel that access to a GP is challenging, but worth persevering with. Some are fortunate enough to have private healthcare. They have some, if limited, security. For those who are uninsured, it's very worrying. If you are over 70, private health insurance fees are quoted at between £1,000 and £2,000 per month, and policies exclude any pre-existing conditions. And who gets to 70 or more with no medical history? So most of my middle-class friends are resigned to getting their knees, hips, and cataracts done privately, despite being passionate supporters of the NHS all their lives. Many are very suspicious of private care. So let's just talk about private care. As we heard earlier, no bankruptcies as yet in the UK for failing to pay for healthcare. So private healthcare is driven by profit. It has to be. It's very selective. Bupa, Nuffield do not train doctors, nurses, allied health professions. The NHS does that. And it doesn't bother with the high risk areas such as obstetrics and midwifery. No surprises there. Very little psychiatry, but that is growing with increased demand for treatment for dementia, depression, and more. Long-term care does not make money. So it seems decisions are made on can we rather than should we. A swollen knee following a fall perhaps needs an aspiration, not a knee replacement. My husband's back on his bike, by the way. And for those seeking cosmetic surgery, breast enlargement, varicose veins, even weight loss surgery, yes, they'll say yes, they'll do that. And many tests are ordered because we can, rather than on clinical need. And GPs are being asked to interpret the results without starting at the beginning with the symptoms, the examination, the questions. Politicians on both sides have no idea how primary care functions and what is involved. And the solutions offered, new phone lines, don't solve the problems. And then charities are asked to supply everything else that's missing. For every condition, there is a charity filling the gaps. In the UK, we used to pay taxes to fund healthcare. Now we're asked to fund charities. In Germany and France, they pay taxes to fund healthcare. And as we've heard today, there's many new drug treatments that are being developed, new cancer treatments, and inflation has driven up the cost in all these areas. As there is more ill health in the population, economic activity declines. There are significant staffing shortages, again, as we've heard this evening, and many factors, including Brexit, which has reduced immigration. So as you might have guessed, I believe passionately in the NHS, but I also believe it must be funded by an income tax system. Healthcare is political. It cannot be considered in any other way. Political decisions are choices and shape healthcare in the UK in 2023. But we live in a society that's more unequal than ever. The link between poverty and ill health is well established. The social determinants of health mean that poor people are dying younger and experience more ill health than their wealthier citizens. We now live in the UK in the most unequal society. Racism, ageism, sexism, homophobia is endemic and destroying lives. And the latest outcry about female surgeons being subjected to abuse is widespread, and it's not just surgeons. Black African women are 3 times as likely to die in childbirth. Why? Historical racial trauma, discrimination, marginalization, systemic racism, bias, both conscious and unconscious, within the healthcare systems, sepsis, and more. It's very important to remember that the NHS was set up 75 years ago at the end of the Second World War and was partly driven by the poor state of health of recruits to the armed forces. As then, socio-environmental factors such as poverty, poor housing, unemployment, poor diet, and even the climate is still exerting a negative impact on our nation's health. Sir Michael Marmot, one of my great heroes, says, if your hypothesis was that the government was seeking to destroy the NHS, then all the data are consistent with that hypothesis. I believe that the NHS is not failing. It is succeeding in doing amazing things, despite being seriously underfunded. It is being failed. Thank you.
Thank you so much, Sheila, for wrapping it up so smartly. So now it's open for discussions, and over to you, Sue. Have you got any questions in this?
Thank you very much to all the speakers for really very stimulating conversation this evening. And what's come out is clearly that we have moved very, very far from the origins, particularly with technology, but with that come some distinct challenges, as everyone has raised. So does anyone have any questions, any comments that they'd like to address to any of the speakers?
Nina, I think you blocked my video, so I'm not visible. Somebody has blocked my video. Anyway, it doesn't matter. That's why I'm not visible. So it says
We can.
host have blocked your video. So
Yeah, me too, don't worry.
We can unblock it, right?
Would anybody like to ask a question? Perhaps I can start, because it certainly strikes me that we have come, as I've said, very, very far from the origins. And perhaps Bevan would not have had any concept that there would be, for example, such advances in treatment and in technology. So I guess a general question, given that we have so much that is now possible, and it certainly costs considerably more than perhaps anybody could have envisioned right at the beginning. How perhaps should we be thinking that the future should go if we are not to be entering into a private system, and our tax pounds are not necessarily going to be able to pay for everything that everybody would like to do? Zaheer, you have a hand up. Would you like to open a question, an answer to this question, and ask your own?
Sure. So thank you. So I've got a comment really, and it was also a question to Hamsaraj. So one of the things that he mentioned was that his suggestion was that what we need in the healthcare is more clinicians and less managers. And I completely agree with that. I mean, I was sort of trying to allude to that in a politically sensitive way when I was talking about the shackles being removed during the COVID, when we were actually able to innovate and do lots and lots of things, and the different layers of no's were taken away. But I think so. I think the balance is wrong, and I think it needs to be redressed in some way. But we do need managers, and herein is part of the problem, because actually most of the managers in the NHS are people who have come through the NHS as either porters, nurses, physiotherapists, occupational therapists. They're actually trained healthcare professionals who went to their various colleges or universities to get trained to be that particular healthcare professional. And then they went through the ranks there, and then the next step on the ladder for them is not doing more occupational therapy or physiotherapy and seeing patients face to face, but actually taken away from that arena and going into an office and becoming a manager. And so what we're doing is we're actually making a rock for ourselves, because these highly trained people who are experienced, for them to have any worth in the NHS or any career progression, rather than staying where they are and doing a job which is very, very good and very, very needed and that they're trained to do, they're actually taken out of that environment and they go into the managerial structure, which takes them away from patient care. And therein is part of the problem, because we've got layers, it's like onion skins of these management structures. There are more managers in the hospital now than clinicians, and they're all ex-clinicians or people who are working on the shop floor. And so now they're managing the situation where there are no people on the shop floor. And it's a really dangerous situation to be in. And I don't know what the solution to this is. Do we need a separate degree course in healthcare management? And do we just, appoint those people to be managers? I don't know. So it's most a comment, but also a question to Hamsaraj. And you think there are too many managers? So how
I'll give you one example. Many years ago, Professor Patti was the professor of geriatric medicine, and he was effectively you can consider him like the chief executive for the geriatric service. And under him, there were something like 8 hospitals in Cardiff, right? 8 hospitals were run by one administrator, one secretary, and an assistant secretary. 3 people ran 8 hospitals. And how many managers do we have now? For how many, 3 or 4 hospitals? We have a whole entire wing full of managers. And the question I'm asking, do we really need all of these managers? This is why I'm saying we need to have evidence-based management. We are always told about evidence-based, clinical medicine. We need to critically look at what are all these people doing. And I mean, the problem is I envy managers because it's a very difficult job. They can't, it's a, thankless job in a way, because your job is always on the line and you need to meet the budget, and otherwise your job is on the line, and you don't have sufficient funds to deliver what is needed to be delivered. So it is a difficult, I have worked with some excellent managers. I'm not, criticizing managers as a whole, but I think you can't run health service on the lines of a business, because we are dealing with human beings. There are so many variables which you can't, predict in health service. So you need to have people who understand how health service works. And the best people who should really be running are the clinicians. And I told you, Professor Patty ran 8 hospitals with 3 people. I mean, I think that's how the model should be, where healthcare is run by clinicians. Maybe we need to get support from others, but I think the main people who should be running the health service. But unfortunately, I know some really excellent clinicians, when they apply for jobs, they don't get it because probably they don't speak the language sometimes. So
bring Sheila in. What do you think from a nursing aspect?
Well, I remember Dr. Pathy. He was there in my youth, when I was running around in a yellow dress. And the type of hospital medicine that was going on in those days is absolutely nothing like the type of medicine that's going on now. And I'm totally against the commercialization and bringing in a management system that was designed for industry. That's totally inappropriate. But the complexities of managing healthcare are now that you do need the managers. So I actually don't agree with you. And the fact that if I think of some of the executive nurses, they have come through a clinical route. They know and understand the way health services work. And I was only talking to somebody last Friday. There's a mental health facility in Llandoch. And every Friday night at about 4:30, 5 o'clock, there's a desperate, urgent need to create beds for the admissions for the weekend. Now, to make those sort of clinical decisions, you need a clinical background and somebody who will press the button, send the emails, organize the transport, get the patients out so that the patients can be admitted. So I don't agree with the idea to get rid of managers. I think managers can rotate between clinical excellence and organising a service. The psychiatrist that I've come across in Llandoch, I think it might be my age, but some of them look about 23. I mean, they're just absolutely brilliant in really understanding the complex needs of mental health patients. And they're contributing with the managers to organising the service. So that's where I am on it.
No, I think you probably misunderstood what I said. I'm not saying that we should get rid of managers. We need to be more rational about appointing managers. We should have less number of managers probably in the system than what we have now. So that's what a point I was trying to make. You probably don't need as many. Like I think, when the 22 trusts became 8 health boards, I'm I may be wrong, but I understood that all the managers who were there in those 22 trusts were still kept in their posts. Why? So what was the point of, reducing the number of trusts to 8 health boards if you are keeping all those managers? So, I mean, this is the kind of thing I can't understand the logic of that.
So
Just one thing. One of the things that my swimming gang sit around and say is that the trouble with the NHS is you can't get into the system, but once you eyeball face to face that consultant, it's the best there ever could be. And I think we've got to hang on to that. If you see the real expert in ears, eyes, knees, spot on.
shall we give the last word perhaps to Jo, who runs a highly, highly complex system, about the thoughts on what you've heard? Can you unmute, Jo? I think you're still muted. Can you unmute?
Oh,
yes.
There we are. Yes, I needed permission. Thank you. So I think for me, having stepped out of clinical medicine and gone back, it's how we maintain that clinical voice. And I think that's what Dr. Shetty is alluding to, is how we keep connected. So we all work in the same site. So we see each other clinically a lot, maybe not as much as I'd like to, but we do. And some of the managers that we work with, it's been a long time since they've practiced any medicine, despite their background. And it's how they still understand actually some of the demands that clinicians have, some of the expectations that patients have. And I think when we're having this debate, it's always going back to actually what matters to patients most. And they're not interested in targets or maybe artificial intelligence or predictive analytical tools. What they need to know is they get that right care at the right time in the right place. And I think there is so much more that we can do that bypasses that human bit, but actually delivers what matters most to the patients, if that makes sense. But it's maintaining that clinical voice and that connectivity with patients. That's key.
Agree.
Thank you. Thank you very much, Jo. And I think we probably have to wrap up. But I'm going to hand you all once again for very informative talk, and I'm going to hand back to Meena.
Well, thank you so much. I think we've had excellent talks today. I've got one final question, and it's very small. It won't take very long to answer. We have heard this evening that the clinical practice has changed post-COVID, and we have seen many innovations during the pandemic. My question is, in view of financial crisis, are the new practices going to be sustainable?
So Meena, maybe I can start off answering that. Absolutely. We have shown that we are able to deliver. I work in a specialty where we're very outcome based. So we do an angioplasty. We want to know that the patient is feeling better, that the quality of life is improved. So we collect that data, and one of the drivers for us is that these virtual clinics and these virtual practices and these remote follow-ups and things that we're doing, the patients actually like it, and the outcomes are just as good as they were before. But I think what we have done though is we have continued with that, because also it doesn't cost anything. It actually saves money. In the sort of bigger picture, there's less transportation costs for the patients. There's less days off work for the patients, and actually from a hospital health board perspective, it doesn't actually cost them that much to open up Wi-Fi networks and things. So we're meeting all of that. But I think what's important is that we don't go completely down that route, and there are patients who actually still want to be seen face to face. So we keep that option open as well. So for my clinics, for example, the default is remote. But if I want to see a patient face to face because I need to discuss something with them face to face, then I actually change it to a face to face appointment. Or if the patient wants to be seen face to face, then they have that option as well. So I think the hybrid model is something we need to think about.
But then we haven't had long-term evaluation on new practices. So do you think there is, we need to be cautious about it and regularly return?
Yeah, absolutely, totally. So, I mean, I'm basing this on the qualitative data sets that we've got. So the patient feedback and the problems data and things that they complete. Sort of slightly softer clinical endpoints, but that's pointing in the right direction for us. But yeah, you're absolutely right. How many people are dying from heart failure? How many misdiagnoses of heart failure? That is harder clinical data, and that'll take time to come.
Thank you. Okay, thank you very much, all the speakers. Really excellent talks, very inspirational and thought-provoking. And I cannot thank you enough for your presentation. And thank you everybody for joining this lecture tonight. And we are hoping to arrange the next conference on health inequalities next year in June. So I might get back to some of the speakers today. I think you all touched on inequalities. I was so pleased, and I said, "Oh, I've got my speakers here today." Don't you think so, Sue? We were discussing. We've got the speakers for our inequality conference next year. So thank you once again, and most grateful. Good night. Have a nice evening.
Thank you.
Bye-bye.
Bye.
Oh.